the session is open for.
There is an online question. I think it is for Channa. Uh, this person is asking, how do you select the size of the spacer?
Yeah, good question. I didn't discuss it. We didn't have time. Yeah, the selection of the space in children's actually we don't have much selections or choices. We have mainly two sizes of spaces: the large volume spaces called the volumetric spaces, and others are almost equal to the small space. But the principle is child should be able to take the content within the space with 5 to 6 breath, the tidal volume. So it tally with the tidal volume of the child. If a child is older one, he can take the all the content within that space, the volume with a single breath. They can use even with the volumetric larger volume spacer. But small children, so better to use the smaller one. Small ones almost the same the volume, so there's no major differences. So actually currently available with the space, thus we don't have much of a practical issues, but child should be able to take the inhalers or the all the content within the space with the 5 to 6 tidal breath, because otherwise after about 10 seconds the content within the spaces gradually precipitate, and after that I don't think there's nothing much or small amount retained. So sometimes I have seen asked to take breaths 10 to 30 bits, or sometimes keep the space of breathing 1 to 2 minutes even. So there's no point of doing like that. So within 5 to 6 or maximum 10 breaths, I should be able to completely empty the spaces. So that's a usual thing. So because of that, at the moment practically we don't have much problem with selecting the small child. Better to use a small one. That is again practically also more comfortable to use for them.
Can I add to that? Actually, the spacer volume, as you said, depends on the tidal volume. Actually, for adults, it's better to always use a large spacer, and also you have to make sure that the spacer can be opened and washed properly. Because there are some spacers which cannot be washed properly, and washing a spacer once a week is very important. Wash it with soap and water and drip dry it. Like the instruction you have to give to the patient, and and wherever possible, actually I prefer to prefer the patient to take the inhale through the mouth rather than using a mask, because it's more effective when you use even a child. If you can train the child to use the mouthpiece without using the mask, I think it's more effective than using the inhaling through the spacer.
Exactly, sir. Because our nasal cavity is naturally formed to filter the small particles, as I mentioned. So there are a lot of bumps out there. So as much as possible, if the child can manage without mask directly through the oral cavity, just to bypass the nasal cavity, that's better. Exactly. Other thing is regarding this, the size of the inhalers. Some of you have seen this baby inhaler. There's a largest space I used earlier. So that the principle is if the lamina flow, the inhale breath, it become more laminar flow. The deposition is, so it's become more turbulent. If the shorter the spaces, it become more turbulent, and longer the space, it's become more laminar. So that was the idea to use is longer, but now it is not being used practically, and it's almost outdated. But currently we have mainly two types of spaces we can use without any hesitancy. Small children, the small one, as mentioned, that's very correct.
Any other questions?
Actually, not a question, but I just want to tell you, all of you, that anybody who comes across a patient, adult patients whom you come across, always ask, especially if their symptoms are not well under control, ask whether they apply hair dye, right? And hair dye is a very potent trigger factor, whether it's herbal or ammonia free, whatever they call it. If you can avoid hair dye, actually that there are people who have applied hair dye and got exacerbations and died also. And there are patients who have who have come off hair dye and got their symptoms better, and the inhalation, the treatment can be could be tailed off. So that I think personally is a very important trigger factor when it comes to asthma.
Just a question to Dr. Paramesh. I wonder if Dr. Paramesh is online. Is Dr. Paramesh online?
Yes.
Yeah, just what about the costs of this costs? Good afternoon. This what about the costs of this biologics in India? How does it relate to do you have any idea of the different costs of the different biologics available in India?
Yeah, as far as the omalizumab is concerned, thank you for the question, sir. Omalizumab is concerned, one vial of biosimilar, which is available in India, one vial means 150. 150 milligram of this omalizumab is costing a maximum retail price of around 13,000 rupees. To the max, if you are using 600, the maximum dose, then it will cost around 52,000 rupees MRP. And there will be some patient support program as well doing by the companies where after 3 vials, a patient may get 1 vial free of cost, but that for selected subset of individuals. So that is for the omalizumab. Second, that is a monthly cost. Second one is the mepolizumab. Mepolizumab 100 milligram auto injector is costing around 75,000 is an MRP, and there is a patient support program done by the parent company. You will get the next month free of cost, 1,000 per month. Likewise, Benral, one auto injector pen, they do also run a patient support program for 6 months. Effectively, the price of benralizumab for 6 months, 30 to 35,000 per month. Because we after 3 doses of benralizumab, we have alternate monthly doses, like 8 weekly doses. After 4 weeks, after the first dose, we take a second dose after 4 weeks, third dose after another 4 weeks. Then we do it every 8 weeks. So effective cost will be around 35,000. So around 35,000 to 40,000 with the patient support program. Otherwise, it will be costing around 75,000 per month on an average.
Thank you very much. Niranjan, I was thinking now with all these discussions and everyone saying that it's so difficult to manage the severe asthma cases, isn't it time that the college has some these things? At least we have a referral center where we can refer our young people who are very, very sick, and some people die. We have experienced that, right? And I'm sure from the President's Fund we might be able to get some help, just like the kidney patients do. Right, if we work on it this time, I think it might be a very worthwhile project to.
Yes, sir, thank you very much. Actually, the reason that for the Asthma Day, we invited the NCD and the ministry as well, so that we can work together. And at the moment, we unfortunately, as I pointed out in the morning, we don't have any biologics at present in Sri Lanka, even in the private sector, if you want to use it. So we have started it actually. We have thought about formulating a dossier about the biologics, and then start at least a MDT based discussion before prescription of biologics, rather than haphazard prescription. And then if we have that pathway in place, then we might be able to bring the biologics into Sri Lanka, at least starting from omalizumab, which is already registered in Sri Lanka. Right. So, and Vijit sir actually gave me a challenge. I think you can remember, sir, during the. Yeah.
I sincerely hope that
yes.
the current president and the council will
Yes.
work towards
hopefully,
making
yes,
biologics available
yes.
before the end of their tenure.
Yes, hopefully by by next year, at least we might be able to start using omalizumab we will try to get it done. But we know that the registration process is very, very cumbersome. So probably we might have to start the process of registering, probably not mepolizumab, but dupilumab, because it has a very good interleukin 13 and 14 activity, which has shown more prominence than mepolizumab. So probably we might have to target certain biologic agents, and we might have to work on it with the ministry as well as.
Unfortunately, even to get the clearance, it will
Yes.
be very difficult because
Yes.
it takes years.
Yes.
Unless
Yes.
we push very hard, it will be difficult.
Yes.
Yes, so omalizumab at least we
At
can.
least if we can bring omalizumab by the end of the year.
Yes.
The thing is, these drug companies, when they look at the business perspective.
Yes.
And we should be having a mechanism in place where we will be able to prescribe it. So rather than haphazardly prescribing, if we can develop, we are planning to actually develop a MDT based discussion. So any patient with severe asthma, even we can have a Zoom MDT with the concurrence of a specific elite membership group, and then if we decide on omalizumab, then probably we might be able to go towards it. So we can actually do a trial asking them to refer these severe asthmatic patients and then do the initial workup, because most of these investigations we can do very easily. Eosinophil counts, the phenos even, we can do most of the investigations very easily. So if we can do it, and then we can look at how much proportion of people will need omalizumab, and then probably we might be able to convince the importers to bring the drug in. So hopefully we will be able to start that process. I have initiated it. I have, I have allocated a council member so that she will be actually looking at it, and probably by the next council meeting we will be able to give you an update about it, sir.
Thank you very much, Niranjan. I think we have come to the end of this session. I wish to thank all the speakers for the excellent presentations done. But just finally, before we conclude, I think on an asthma day, there are two small things that I want to focus on. One thing is, as you all know, there are lots of inhalers being prescribed by a lot of people. But unfortunately, I don't think even 5% of that goes into these patients when you take the population as a whole. Right, because they are misused to the maximum. If you just look at the people who are, sometimes we don't have time to look at the inhaler techniques, but it's thoroughly misused. Nothing goes in, right? And particularly in the elderly, Vijita, I don't know whether you have seen it, that the elderly people who are bedridden and can't use a spacer, sometimes the mask is useful in bedridden patients with Parkinson's and all that. Right, sometimes it's useful to use a mask, but I think this year, since the theme is for this education, this thing, I think we should go all out and try to give this message of proper usage of the inhalers, because it's a crime, right? Everyone inhalers, if you ask them, they say inhaler dila tiyenne, and you ask them how they are taking, they'll just puff it onto their face. They won't take it. Right, I mean it's a wastage of money, it's a waste of time. And the other thing is, if you just look at the cascade of medication that has come over the years, it is funny. In fact, I was going through the genome myself yesterday, and I find that there is hardly any difference not much of a difference from what we used to go through earlier. Oh, actually, if you look at the summary of it or the crux of it, you'll find that ICS has not changed. Right? Steroids are still life-saving. I think I have my slides that we made 25 years ago, which are saying steroids are life-saving, right? Because we, as a country, had a very high asthma death rate, and we had a big fight, like you all struggling to get the biologics to get the steroids in, the inhaled steroids. We had a huge fight. For years we were fighting. Almost 10 years we had to fight to get the steroids in. And after the steroids came in, that the death rate came down. But yet, this message is not adequately dispersed among the medical fraternity, right? That it is the steroid molecule that will save the asthmatic, and now you come up with this this thing that even the mild asthmatic needs that. But even that, about 15 years ago, that was shown. But still, this is not applied because a lot of people are very scared to use it, and the suffering goes on. So I think this is something that we need to address and have massive, because we have so many of our colleagues in the peripheries if you can conduct so many training programs or lectures or something to uplift the knowledge of people, because then I'm sure the management of the quality of the management of asthma will improve. Thank you.
Just remember the key to asthma management. The key to asthma management, junior doctors, is the proper inhalation technique, right? Not so always check and recheck the inhalation technique, because no point in giving prescriptions for inhaled steroids without checking the inhalation technique, which is what I mean. I personally do it myself. I know you all are busy with all your other commitments and all that, but that is very important, and that itself will make your patient better.
Fine, sorry for taking this time. This the thing is, we have our inhaler trainers, but what we don't understand is that inhalers are quite foreign to people. We don't understand that. But when a patient is given an inhaler, it is something very, very foreign that is given, not like a tablet. So therefore, that fellow rattles off something, your inhaler trainer rattles off something and says, I'm a train kala tiyenne yanna. But the moment you go home, you can't remember anything. You see, and the thing is, they are not tech savvy as well. They don't have access to all internet and everything. Most of the people. So we have to understand this situation. I have seen so many inhaler trainees. They go through the process so rapidly that the patient is more confused than what he came with. Right. So please be aware of that, because it's very important. Otherwise, it's just a waste of time. Thank you. I think we can proceed with the rest of the program.
Thank you very much, sir.